Good morning, everybody. You all are welcome to the Wednesday CMD lecture series organized by Candy Society of Medicine. Both the physical and online participants are welcome. Today, let me introduce the speaker today. He is Dr. Chaminda Jayalath, consultant obstetrician and gynecologist, teaching hospital Peradeniya, and he is the senior lecturer, Faculty of Medicine, University of Peradeniya. He is the product of University of Peradeniya, and he got his MD in 2011, and he's got foreign training with Cross University Hospital, London, UK in 2013, and he's a member of Royal College of Obstetrician and Gynecologist. He has got many publications nationally and internationally, and also he's a co-author in chapter on bleeding in late pregnancy and departum hemorrhage in the book Differential Diagnosis in Obstetrics and Gynecologist and A to Z. It's over to you, Dr. Jayalath, to talk on pre-malignant condition of the cervix and its management.
Thank you very much for kind introduction, Dr. Jayalath, and good morning, all of you. So I'm going to discuss present on the pre-malignant condition of the cervix and management. So in this my lecture, I hope to cover about epidemiology, pathogenesis, and cervical cancer screening, and classification of cervical pre-cancer, then management and treatment, and a little bit about HPV vaccination. So the epidemiology wise, worldwide, it's around 500 new cases reported. Cervical cancer, 500,000 new cases reported every year, and there are about 274,000 deaths every year. So this is common malignancy in developing countries like in India, Sri Lanka, and the developing countries. It's account for 80% of all the cases worldwide. At peak of incidence around 30 to 40 years of age, then it declines for older group, and then again there's another peak around age of 80. And in Sri Lanka perspective, it is the second most common female malignancy, and it's account for 12% of newly diagnosed cancers in Sri Lanka. And incidence wise, it's about 9.6 per 100,000. And for the recent years, we have they have calculation that's around 1,721 new cases and 690 deaths per year. By its recent statistic. So, what is the etiologic factors? So, you all know this is mainly caused by human papilloma virus. This is the cause for pre-invasive and invasive carcinoma in almost 100%. There are mainly now HPV. There are a lot of types. Out of that, there are mainly few types that are oncogenic types. That's 16, 18, 31, 33, 35, 45, 51, 52, and 56. Out of these, the 16 and 18 is responsible for about 70% of cases. Now, other etiological factors include that having multiple sexual partners and partners' sexual promiscuity in male partners, then the young and early age of first intercourse. And other etiological factors include smoking, then immunosuppression, which include HIV infection or post-transplantation with medically be immunocompromised, and high parity also associated with CA cervix in the low socioeconomic status. In Sri Lanka perspective, that's early age at first sexual intercourse and early pregnancies have been recently evidenced as risk factors, especially in developing countries. So, cervical pre-malignancy. Now, this is before it become a malignancy. We call it pre-malignancy. So we call CIN, cervical intraepithelial neoplasia, or CG, cervical glandular intraepithelial neoplasia. So as I called just earlier, that HPV is the necessary cause. Then there are high-risk HPV types causing that. So 80 to 90% will have the infection in lifetime. Now, this is something important. Now, everybody that if we got every people in lifetime, 80 to 90% of everybody getting infection in one time. Now, the importance of not getting infection, if it is persistent infection that cause pre-cancellation, so it's persistent in 10% in females and 6% in males. And cervical is rare complication of common disease. As I said, now 80 to 90% of us having this HPV infection in our lifetime. So if it is persistent, then it causes precancer and malignancy. So it's a rare complication of common disease. So if you think about us now, if all of us getting 90 to 80 to 90% infection in our lifetime, that is common disease, then it's rare complication when it is persistent. So viral carcinogenesis, mainly it's first thing, it should be exposure to HPV, human papillomavirus, that is, it should be oncogenic type. Then the infection should be persistence. Then this infection become immortalization. Then it goes to precancer stage, that's CIN and C gene. Then it goes to invasion. So this is the pictorial description now. It's normal cervix, then it infected HPV. Then there's a transient infection, goes to, we call it CIN or productive infection. That's majority of them clear itself and become back to normal. Then if this CIN1 level progress, then it becomes to CIN2 and CIN3. That is precursor lesion for the invasion lesion. Then CIN3 can go to the invasion lesion, or CIN3 can, small amount of CIN3 can go back to CIN1. So we all should know that there's a very good screening program for cervical cancer prevention. Now, when we consider about screening program, there should be certain criteria. So it should be an important health problem. Now, as I said, it's an important health problem. If around 500,000 new cases every year see a cervix, that is an important health problem. Then natural history should be well understood. Now we know natural history-wise, is caused by HPV infection. Then should be treatable early stage. Now, if we treat at the early stage or precancer stage, we can cure this. They should have an effective treatment. So this treatment we'll discuss later. And there should be a safe, simple, precise test. Now, when we are discussing about test, we will all see that it's a safe and simple and precise test. Test should be acceptable, and interval for repeat test should be determined, and risk should be less than the benefits, and it should be cost effective. So when we consider about cervical cancer screening, it goes with all those criteria. So cervix has a long natural history and long premalignant stage. So before it's become invasion lesion, it has a long premalignant stage. So cervix is accessible and simple test. Now we can put a speculum and get a sample from cervix. Then intervention and treatment in premalignant stage is curative. Now, if we treat at the premalignant stage, identify and treat, it's curative. Then it's cost effective, because once it become a malignancy or advanced stage, so cost wise, if we can prevent that malignancy in the like a simple test like that, so it's important. So as I earlier discussed, now natural history, we know that CIN1, as I said, 50 to 60% of CIN1 regress and 30% persist. Now we all see that CIN1, majority of them go back to normal cervix. But CIN3, 33% regress, but 60 to 70% persist. And peak age of CIN about 30 years, and cervical C is 45. And HPV 16 and 18 responsible for 70% of CA cervix. Now, as I said earlier, there are a lot of other oncogenic type. Out of that, 16 and 18 are the most responsible for CA cervix. Now we'll discuss about prevention of cervical cancer. So how we can prevent it primarily? So primary prevention is vaccination. Then barrier method of contraception, it's preventive method. So some people say this is a sexually transmitted cancer because now HPV goes with sexual intercourse. So it's if you use barrier methods for contraception, there's a preventive method as a primary prevention. Then avoiding sexual promiscuity. Then HPV vaccine. So a bit about HPV vaccine. Now it has been introduced. Initially, it introduces bivalent one that is for the cover HPV 16 and 18. As I said, those two are responsible for about 70% of CA cervix. So initial vaccine contained that two types, then covering two types. Then the quadrivalent one that is Gardasil we call that 6, 11, 16 and 18. That immune-wise that is more protective compared to bivalent one. Then recently they introduced nonavalent one. It covers 9 types, that's 6, 11, 16, 18, 31, 33, 45, 52 and 58. So this we call Gardasil 9. It covers 90% of infection. 90% of prevention is there. So if it is less than 15 of years, they give 2 doses. Ideally, it should be given before the first sexual intercourse, that is around 90 to 14 years. And if it is more than age of 15, they give 3 doses. Now, after this introduction of this program, now that 15 years and above group is not there, now we are giving 2 doses around 10 to 12 years of age. Now, Sri Lanka also started this vaccination program for females. And so this will prevent 70% of CA cervix. But now recent study, they said it the Gardasil 9, it prevent almost 99%. But one thing we want to remember, even somebody got vaccinated with HPV vaccine, still they need to go for cervical screening. The reason is that this is not 100% cure with this or prevention by this vaccine. Right, now about the secondary prevention. So secondary prevention, mainly our intention is to detect it at pre-cancer level and treat. So it is screening, cervical cytology we do with pap smear, and it's high specificity and low sensitivity. Then the newest thing of the use is HPV DNA testing. So we test HPV for DNA types, and it has a high negative predictive value. If it is no HPV, that means unlikely they are going to have a that if there's no oncogenic HPV types, then unlikely they go into CA cervix later. Then the third type is colposcopy. So colposcopy, actually we refer them after this cervical screening program by cytology or HPV typing. Depending on the results, we refer them for colposcopy. Now, this is bit about cervical screening program. Now, UK, what they have said that they have reduced CA cervix almost by 90% by well-organized cervical screening program. Now, earlier they did it with the pap smears. So with the GP system, they have well-organized. Australia and UK both they are doing it very well. So they have very well-organized cervical screening program. So they have reduced the CA cervix almost by 90% according to results. Now what they do, they send by GP, you know that UK, they're having very good GP service. Through GP, they send a reminder that you are due for screening programs, you are due for your screening, cervical screening. So if they delay, then they send that you are overdue. Then they remind the patient to come and get done. So by like that, they cover almost 80 to 90% of population, those who need cervical screening. Australia, that now, I have to tell this. Now they have changed this program to the DNA testing. Now they go with the DNA, because not the pap smear. Australia, their frequency-wise, they do from age of 25 up to 55 yearly, 3 yearly. Then after 50, they do 5 yearly, up to 65 years of age. Australia, earlier what they did with the pap smear every 2 years, after 25 years of age, now they changed to DNA testing, HPV DNA. So they do after 25 of age up to 75 years of age, 5 yearly. when we discuss about Sri Lanka, now we don't have a well organized program for HPV screening, right? Not a cervical screening. Now what we do opportunity screening, right? So we ask at MOH level at age of 35 when we are doing well woman clinic to do a screening at 35 years of age and repeat it in 10 years, that 45 years of age. Now just think about yourself. How many of your sisters above 35 or how many of your wife above 35 had HV, that's cervical screening program, at least one pap smear. So majority of even doctors, they will say no, right? Even doctors themselves not having this thing done. Now important, as I said earlier, we might think this is a poor people disease or the disease of somebody having sexual promiscuity, early sexual development. Those are people getting this thing, so we are not going to get this. But we have to think that almost 80 to 90% of people get this infection once in their life, right? So even we have that possibility. Now I'll tell one story. Now recently I had a patient who came from Bibila who had abnormal vaginal discharge, which earlier profuse discharge, then it became a blood stain, and she had history of postcoital bleeding. Now she had been seen by a lot of doctors, GPs. Then even she has been seen by consultant, has done an abdominal scan, right? So by the time she came to me, so even at private sector, I usually do vaginal examination if needed or indicated, or even speculum examination. So I look at that. It was a malignant lesion. So she had been with these symptoms for 1 year. By the time detect, it has beyond the treatable. I mean, that beyond the surgical operative level. So I had to slip her post. I mean, that's radiotherapy, right? So she's a teacher and very good knowledge, and the failure is from our side, right? So if she had, if you don't have facilities to check, they could have referred them for a gynae clinic in a hospital to do a speculum examination or get a biopsy. If we detect it early, even in the invasive stage, at the early stage, we could have done a birth hysterectomy or that cure that thing with the surgery. But by the time it was spread massively. Another thing happened in my life that about 2 years back. One patient came with, she had 7 sons, right? Only sons. So lovely thing is the all 7 sons came with that patient, and they said about some blood stain discharge. So mom has not told these boys for some time because she tried to tell these things. So then she has told this to some of daughter-in-law. Then they got this woman. So that time even that one was spread beyond the operable level, but there's a possibility to get done a radiotherapy. So that time itself, I called Maharagama and arranged everything next day clinic. I mean, it's within 2-3 days clinic in the Maharagama to get done this radiotherapy. But I didn't know anything after that. So after about 3 months, they brought his mom, right? They say that they have Ayurvedic treatment and they want to check this whether it's cured, right? So by the time when I look at the vulva, it has spread even outside the vulva. So nothing could be done. So it's spread even beyond the radiologic, the only palliative care. So message I want to tell that anybody, if you have any doubt, if you can't do vaginal examination or speculum examination, just send to gynae clinic in the hospital. We can assess, we can do pap smear, or even we can get a biopsy or whatever. Right. So Sri Lanka, even that 35 years opportunity screen, the cover is it's less than 25%, I would say. Right. So if you think about yourself, your sisters, or your mom, or your wife, or yourself, majority of us not got done at least one. Right. So cervical cytology, its exfoliative cells are taken. So specificity around 98% and sensitivity is 70%. So if you get liquid-based cytology, that improve the sensitivity and reduce unsatisfactory smear test. This is how we take that look at the cervix and get the pap smear. So with the pap smear, we get a result which says Bethesda system. So it would say that now basically I'm going with this our system, but how it work here, type, but in the UK and Australia now it changed. So they get HPV typing, depend on the high risk type, whether it's 1618 or other oncogenic type, their management depends, right? So if they HPV detect H1618, they do core test, that is smear test alone. And even without smear test, they send for colposcopy straight if they detect 1618, right? The reason, as I said earlier, that is those are the two culprit cause for around 80 to 90% of cases. So our system, we do that smear test. So with the smear test, its results comes as NILM, that negative for intraepithelial lesion or malignancy. Then LCL, that is low-grade intraepithelial lesion. Then HCL is high-grade intraepithelial lesion. So ASCUS means atypical squamous cells, AGC means atypical glandular cells, and sometimes if we detect endometrial cells in our pap smear, if the age is more than 40, there's a possibility of endometrial CA. And the pap smear itself sometimes will tell the result it's squamous or glandular malignancy, right? So usually with the pap smear, at the end of that pap smear, they mention about comment and recommendation. What is they have to get done next. So diagnostic wise, when you look at the pap smear, we see coilocytes, that is a hallmark of HPV infection. So we see atypical enlarged hyperchromatic nuclei and prenuclear halo. So you will see that there are coilocytes here. So the nuclei enlarged and atypical nuclei are there. So those are the features suggestive of HPV infection. So this is how it managed. I mean, if it is normal, so they go into normal routine screening 5 yearly, right? So if the ASCUS, that is low-grade ASCUS, atypical squamous cell of undetermined significant, then they can manage at medical officer at primary level, and they can repeat that smear in 6 months time. If it is ASCUS high grade, then they have to refer for colposcopy. If so if we do colposcopy, I will tell about colposcopy. At the colposcopy, if we detect abnormal area, we get biopsy at that point. And if the biopsy positive, then we go for treating as HCL. So LCL means that is in the categorically we say CIN1 like, including flat condylomata. Then if it is now, as I said, CIN1, majority of them can return back to normal. So, but until they're back to normal, we have to check them. So we repeat smear in 6 months. If they get 2 LCL reports now, that repeat smear again LCL, then they have to refer for colposcopy. Right. And HCL means that is histologically CIN2 and 3, they are premalignant. So they have to refer for colposcopy, and colposcopy we get biopsy. And if there's a glandular cell atypia, this is one thing that I will tell more about that. That is something that's not going on the routine way. So they straightforward, they have to refer for colposcopy. And invasive carcinoma, there should be urgent referral. Now, if pap smear say that it's likely to be invasive carcinoma, then they have urgent referral for tertiary care center for gynaecologist opinion. Now, I just briefly tell you about HPV DNA testing. So, as I said, it's HPV is the oncogenic HPV is the necessary cause. So, if the HPV says it's negative, that it's have a high negative predictive value, that good thing we can exclude possibly. And sensitivity and specificity wise, it's 85%. So, with this HPV DNA testing, we can triage patient where to go, whether we go for colposcopy or not. And again, this HPV DNA testing we can use after treatment, like lead soap-on biopsy. We can use this thing to see the cure after treatment. So the best thing is that more sensitive tests we do first, then more specific tests we do second. Now we call it, in Australia they do it as a core test. So HPV depend on HPV typing. If it is HPV 1618, straightforward they send for the colposcopy. If it is oncogenic HPV types other than 1618, they do core test, that is pap smear, and depend on them, they decide the next management stage. For screens frequency, I already told that the UK do 3 yearly up to 50, after 55 yearly. The Australia, they do now 5 yearly with HPV DNA. Sri Lanka, we do opportunity screening at 35, but even that thing not happening very correctly. Right. Very good colposcope, video colposcope. Like a laparoscopy, right? And it has a magnification. Then we can use green filter to enhance visualization and red pigment. And we apply acetic acid. Now, the malignant cells contain a lot of protein. So when you apply acetic acid, if the malignant cells or that highly dividing cells, the cells will stain with the acetic acid, and we can see it as an acetobite area. And again, iodine, we can use iodine to see the normal cells. Normal cervical cells contain a lot of glycogen, so those cells will stain with iodine. If the cells not contain a lot of glycogen, then those cells, the malignant cells, not stain. This is how we do the colposcope. Look at the cervix with magnifying view. As I said, now the newest one, we don't need to keep our eye there. We can just focus and see at the screen like we are doing laparoscopy. Right, so the colposcopy parameter, now once we do the colposcope, we document the thing. So we have to document whether it's satisfactory or not, whether we can see that the transformation shown clearly. Then we have to document about vascular pattern. If the punctuation and mosaicism is there, that's abnormal. Then we have to say about degree of acetobite staining. It's a mild staining or thick staining. And border characteristic, we have to mention whether we can see upper border of that acetobite area and transformation zone and surface pattern and surface area. So this is the colposcopic view. You see now you can see that acetobite areas. Those are the abnormal areas. So colposcopy, we tell that we see, select, and treat. Now we look at the cervix and select abnormal area and get biopsy, and we decide the treatment depend on that. So with that, the histological diagnosis with biopsy, we go for excisional treatment or ablative treatment. Excisional treatment include LEDS biopsy or cord biopsy. But as I said earlier, that cervical glandular intraepithelial neoplasia is something different from that squamous neoplasia. So different is it's difficult to diagnose cytologically and colposcopically because it's having no specific pattern when you look at there. And also it has a high false negative as well as high false negative rate. And it associates 30 to 45% of squamous lesion. And other important thing is it has a skip lesion. Now, squamous cell premalignant lesions, they continuous lesion. Now, this one, it can have a skip lesion. So you can have a lesion at here and another lesion in the cervical canal. So we call it satellite lesion or skip lesion. So that's why when you are getting that cone biopsy, you have to get a good depth of the cervix when you're treating that premalignant. And also it has a short natural history and patients are younger than CINN. So these patients with glandular neoplasia, they short from the detection of glandular neoplasia, they can extend the malignant course very soon. And usually this condition present in young age people. So if you detect incidental finding of endometrial cells on pap smear, if the woman is postmenopausal, those women need to investigate with DNC to see whether it's endometrial cancer. Right, so these are the my take-home messages. So cervical cancer is a rare complication of very common infection. So as I said, we all get infection. male, female, both, around 80 to 90% in our lifetime. Then it is highly preventable disease. If you detect the thing early, we can completely cure. So it's curable at early stage. But if we go beyond that, it has spread, then nothing we can do. Only conservative, that palliative care. Both that. Then the missing that opportunity is miserable, right? So my main message I want to give is, if you have any doubt, if somebody complains of abnormal vaginal discharge or blood stain discharge, postcoital bleeding, right? Then don't take time, don't give any antibiotic or anything. Just refer them for a gynae clinic, hospital clinic, right? There they will look at the cervix, and if need to get, they will just get pap smear or the biopsy or colposcopy, whatever the thing they will arrange. Rather than giving antibiotic for reassurance, just exclude the possibility of malignant or pre-malignant thing. Then it's because it's, if you detect and treat, it's curable cancer. So in my experience, that when we were medical student in Peradeniya, we got a lot of CS cervix patients. Majority of them are estate sector people, right? Those who work in tea estate Tamil people, right? Even when I work in Valimada, I got a lot of patients like that. Majority of them, by the time they present, in the advanced stage, right? So at least give this message to your known people. At least get done one pap smear. It can be done in our clinic. It's a simple test. We put a speculum and get a biopsy test. So a lot of people, when we ask about whether pap smear done, they will say that they got done, but they don't know the results, right? The reason is, if the pap smear is negative, we don't send usually any report, but if it is positive, definitely we will get them done. Right. Thank you so much for listening.
Thank you, Dr. Chaminda Jayalath. So, if you have any questions, you can. One question: has barrier method reduced the number of incidents? So, barrier method.
Yeah, that barrier method, as I said, now this the HPV infection is sexually transmitted. So barrier method definitely, like other sexual disease prevention, it will prevent infection, right? Because now anybody can get infection and clear itself themselves without doing anything. But at the time of infection, if they get intercourse, they can expose. The other thing, the young age, the problem is their transformation zone. Now this transformation zone is the area vulnerable. Those area cells are the getting infection and persistent infection and go into the changes, right? So that is the reason that when they have a first sexual intercourse, because at the young age, their transformation zone exposed to outside. So that is why they are more vulnerable.
Chaminda, thank you very much. So, may I cordially invite Dr. Kanchanidri Singh, the President-elect for the next year Candy Society of Medicine, to hand over token of appreciation. Online participants, and so one announcement. KSM annual academic session will be held on 24th and 25th of March next year, and it's open for your research publications and the abstracts. You can log into the KSM website and follow the links, and refreshment will be provided.